Welcome to AETCM, the emergency medicine channel. Today let us discuss about one of the important drug which is used in emergency room, that is adrenaline, or sometimes it is called as epinephrine. And most common and most important use of this adrenaline is anaphylaxis. We will see what is adrenaline, what is anaphylaxis, all these things in detail. This is also known as epinephrine, adrenaline or epinephrine. Some countries it is known as epinephrine, some countries it is known as adrenaline. It's a catecholamine hormone and medication. That means it is produced inside our body. It's a catecholamine type of hormone, and that try to maintain our hemodynamic status. And whenever there is that status is going down, like severe bradycardia, cardiac arrest, bronchospasm, anaphylaxis, all these things, we use this as a medication also. Something like insulin. Insulin is produced inside our body, but when there is a deficiency, we give it from outside. This hormone, adrenaline, and norepinephrine, something similar to that, is produced from adrenal glands. You know that adrenal gland is situated above the kidneys. It plays an important role in the fight or flight response by the increasing blood flow to the muscles, cardiac output, pupillary dilatation, and sometimes it also try to regulate the blood sugar mechanism along with insulin and glucagon. As a drug, it can be used in conditions like anaphylaxis, that is the most common condition where we use adrenaline in emergency room. Cardiac arrest, one of the important drug which can be used to save the life is adrenaline. And some conditions like to prevent the superficial bleeding, especially from the nasal bleeding, also we use it. Other uses are like we can use it in hypotension along with noradrenaline. We can also use this drug in asthmatic attacks, that means severe asthmatic attacks where the patient is not improving with regular medication like salbutamol nebulization. Adrenaline nebulization can be used, but it is not a commonly recommended textbook drug. It's a sympathomimetic catecholamine. So it is available as a clear, colorless, sterile solution which contains 1 mg per ml. To avoid confusions, they have prepared like that. Each ml contains 1 mg. Now, the major uses are anaphylaxis, cardiac arrest, and hypotension, especially when it is associated with septic shock. We can use adrenaline as a second line or third line drug in many hypotensive conditions. Whenever there is hypotension, we normally give IV fluids like normal saline or Ringer lactate as a first line drug. Second line, we give noradrenaline. Along with noradrenaline, after noradrenaline, we can start adrenaline or dopamine or dobutamine, vasopressin, like that. Various drugs can be used. So one of the drugs which can be added to the regime to maintain the BP is adrenaline. The most common condition where we use adrenaline is anaphylaxis. It can be due to insect stings, insect bites, food allergies like nut allergy, cashew nut allergy, or some other groundnut allergy. Many drugs including penicillin induced allergy or anaphylaxis. When we are giving any serum containing injections or any other condition, if the patient develops severe anaphylaxis, breathing difficulty, asphyxia, all these conditions, we can use hypotension, we can use adrenaline. So the dose in anaphylaxis and cardiac arrest are both different. Adult dose is 0.3 to 0.5 mg, that means 0.3 to 0.5 ml. Undiluted adrenaline can be administered intramuscularly or subcutaneously, not IV. That is very important. In the anterolateral aspect of the thigh, up to maximum of 0.5 mg or ml per injection, repeated every 5 to 10 minutes as necessary. Monitor patients' clinical conditions and cardiac events like tachycardia, hypertension, all these things. Children, the dose is slightly different. You can calculate per kg body weight 0.01 mg per kg or 0.01 ml per kg of undiluted adrenaline administered intramuscularly or subcutaneously. So that is very important. We should know the dose and we should know the route also, anaphylaxis, because anaphylaxis is a dangerous emergency in condition. Most of the time we have a tendency to give this drug as IV bolus or IV infusion. That is not required. IM is as good as IV here, or IV is more dangerous there. So we should never try IV without a proper guidance of an expert. So IM or subcutaneous can be given. If we are not confident enough to give IM or subcutaneous adrenaline, we can even give nebulization also. So nebulization is a safe route of adrenaline, but the recommended route is always intramuscular or subcutaneous. That is very, very important. So whenever there is an anaphylactic reaction due to any reason, the patient can have swelling of the lips, swelling of the oral cavity, mucosa, swelling of the tongue, difficulty in breathing, bilateral wheeze can be there. Some patients there will be absolutely no breath sound. That is because of complete obstruction of the airway. Some patients can have hypotension, some patients can have tachycardia. So hypotension and hypoxemia, these are the most important signs of anaphylaxis. Hypoxemia is due to bronchospasm and obstruction in the upper airways. Hypotension and other things can be due to anaphylaxis itself, due to a lot of mediators can produce mediated release during this anaphylaxis, or allergic reactions can produce severe vascular collapse. So acute onset of illness, life-threatening airway problem or breathing problem, and acute circulatory collapse, and some skin rashes, especially on the face and chest and all. We can see a lot of skin rashes. Then we have to suspect anaphylaxis. Like any other emergency, whenever you are alone, we have to call for help. Inform the numbers which is given in the hospital protocol for help. Be ready for managing any type of emergency. Then adrenaline should be given. Adrenaline dose we have already discussed. It is 0.5 ml or 0.5 mg. IM should be given. Children, the dose may be 0.01 ml or the dose prescribed in the previous slide. You have to see. So whenever there is an anaphylactic reaction, we have to block both H1 and H2 receptors. That is also very important. Along with adrenaline, we have to prevent the H1 and H2 receptors of allergy. So we can give ranitidine and avil. Avil is chlorpheniramine maleate, CPM. So ranitidine and avil both should be given. Some try to give only avil tablet or avil injection. We have to give both H1 and H2 blockers. The third drug will be steroid. You can give injection hydrocortisone 200 milligram IV stat. Steroids are not going to work immediately. So immediately it will never produce any anti-inflammatory action or anti-allergic action. It takes some time to prevent the second or third wave of attack. So initially we will be giving, so any patient who is having anaphylaxis, take care his airway, breathing, circulation, put 2 IV lines. That is very, very important. Then give 1 intramuscular injection of adrenaline, then give injection avil and injection ranitidine, both should be given. injection hydrocortisone can be given. Then reassess the patient. That is very important. Some patients will improve very fast. Along with this adrenaline, if the patient is having severe wheeze, you can give salbutamol nebulization or even adrenaline nebulization. So if you are not confident enough to give adrenaline as IM or subcutaneous, you can even give nebulization, but that is not the recommended route. It is IM or subcutaneous, not nebulizer or not IV. But if the person who is not trained to give adrenaline, he can very well give nebulized adrenaline. Now, cardiac arrest, the dose is slightly different and the protocols also slightly different. So this is the cardiac arrest chart. I am not going to the details of cardiac arrest. So whenever there is asystole or pulseless electrical activity, asystole means you can see a flat line in the monitor, see the pulse, there is no pulse, and flat line on the monitor means it is asystole. Pulseless electrical activity means pulse is not there, but there is an electrical activity on the ECG monitor. Whatever it is, patient is not having adequate cardiac output or heart is not pumping properly, we have to start CPR and we have to give epinephrine or adrenaline. I am not going to the part of CPR now because detailed CPR classes are given in the previous classes, so I am not going to that. But adrenaline is the most important drug to be used in asystole or pulseless electrical activity. So you can give adrenaline 1 mg every 3 to 5 minutes can be given. So you need to have a central line for proper management of this type of cases, and sometimes we'll have to start as an infusion also. If the patient is having improvement in first or second dose of adrenaline, we can even start infusion of adrenaline, 1 mg of epinephrine to be diluted in 250 ml of normal saline or dextrose water, and 1 microgram per minute and increased to 3 to 4 microgram per minute can be continuously given. So all these sympathomimetic like adrenaline, noradrenaline, when we are giving continuous infusion, we have to always make sure that we are giving through a central line. In emergency, you can use 1 or 2 shots of adrenaline through peripheral line, but if we are continuously giving through peripheral line, then there will be a possibility of digital gangrene and upper limb gangrene can occur because of the severe vasoconstriction. So you need to have a central line for continuous infusion. 1 or 2 doses like cardiac arrest, the patient improves and if he attains the proper circulation, then it is okay through peripheral line. So 1 mg every 3 to 5 minutes can be given as bolus doses in cardiac arrest. Now in septic shock or some shocks like this, like a patient is having fever, shock, we suspect septicemia induced shock. All these conditions we use noradrenaline than adrenaline, but I am just touching the adrenaline here because this is also a very good drug. When noradrenaline is not giving very good clinical outcome, we can use this drug also. So whenever there is hypotensive shock in sepsis, we always try to put 2 IV lines like what we discussed previously. 2 IV lines. Start normal saline as first treatment option, normal saline or ringerlactate 30 ml per kg, then continuous infusion. Try to maintain good urine output. That is the most important treatment. If the patient does not improve with your initial treatment, then we start noradrenaline. Then if patient does not improve with that, we give steroids like maybe patient is having refractory hypotension, then we have to use steroids like hydrocortisone can be started 50 mg every 6 hourly can be given. But along with noradrenaline, we can use vasopressin or dopamine. If the patient is having bradycardia, we use dopamine along with noradrenaline. If the patient is having tachycardia, we use vasopressin along with noradrenaline. Another important drug is adrenaline. We can use adrenaline along with noradrenaline the dose will be something like 0.014 microgram per kg per minute infusion. But there are some adverse effects for noradrenaline infusion because it produces unwanted tachycardia, some cardiac dilatation, all these things. So it is not a first line recommended drug, but if you go to the ICU, you can see a patient in severe hypotensive shock. He will be on multiple inotropic supports. He may be on noradrenaline, dopamine, vasopressin, adrenaline, like that. So many supports may be there on patients through the central line. So these drugs can be given, and it gives very good response also, but there are side effects like it produces severe tachycardia, cardiac dilatation, peripheral vasoconstriction. All these things are the adverse effects of adrenaline. But noradrenaline, comparing with adrenaline, it's a safer drug. Now you can see here, any hypotensive state, the most important drug will be norepinephrine, noradrenaline or norepinephrine. But all other drugs like dopamine, vasopressin, dobutamine is a very useful drug along with noradrenaline when there is a cardiac failure. So if there is a cardiac failure with hypotension, initially to improve the BP, we have to start noradrenaline, then we start dobutamine. But whereas if there is no cardiac failure, we go for vasopressin, that may be the second line drug, then dopamine if there is bradycardia, and the third line drug may be adrenaline. Now some conditions like severe asthma, it is off-label use, we can use adrenaline because adrenaline is a very good bronchodilator like salbutamol. The similar action may be there, but routine practice we don't use adrenaline for bronchodilation. We use salbutamol and ipratropium bromide. Salbutamol dilates the bronchus, especially the large bronchus. Adrenaline also has got same action, but it is not routinely used. So initially we may give 3-4 continuous salbutamol nebulization. Then if the patient does not improve and if you feel that salbutamol is not working, we can use adrenaline nebulization. 3 to 5 ml of adrenaline, 1 in 1000 is safely given as nebulization, but we have to be very careful. This can produce severe tachycardia. So initially take only 1 ampule of 1 vial of adrenaline, that means 1 ml of adrenaline, dilute in same amount of saline, then give nebulization. Watch the patient. If there is an adverse effects, we will not be able to use this drug. But it's only an off-label treatment. It is not recommended in any standard textbooks. Standard textbook treatment is only salbutamol. There are a lot of adverse effects for adrenaline. That's why it is not being used nowadays in routine practice. Only it is used in selected conditions like cardiac arrest and anaphylaxis. Even in asthma also it is not routinely used. But in anaphylaxis, there is no other drug which can bring back the patient. That is very important. And in cardiac arrest also, this will be the last drug which can save the patient. So we use this as a first line therapy in cardiac arrest. Previously, many doctors used to give intracardiac adrenaline. Nowadays, it is not recommended. We have to give through the IV route only. Diluted adrenaline should be given through IV route. So intracardiac has got its own adverse effects, so nowadays it is not being used. So common adverse effects are patient can have tachycardia, anxiety, restlessness, tremors, dizziness, weakness, sweating, palpitation, pallor, nausea, vomiting, headache, respiratory difficulties. But the most important problem or most dangerous problem will be severe tachycardia. If the patient is already having a coronary artery disease, it can produce angina, it can produce acute myocardial infarction, it can produce lot of tachyarrhythmias. So we have to be very careful, and this tachycardia can sometimes produce one type of cardiomyopathy or apical ballooning syndrome that is called as Takotsubo cardiomyopathy. So whenever we are using adrenaline unknowingly through IV route which is not diluted means 1 in 10,000 we have to dilute. That means that 1 ampule of adrenaline can be diluted in 10 ml of saline means it will become 1 in 10,000. So if we are directly giving IV adrenaline, then it will be very dangerous. So we have to be very careful. This patient can sometimes go to Takotsubo cardiomyopathy or apical ballooning. So we have discussed about adrenaline, one of the most important drug in emergency room. So we should know where it is kept in emergency room. Most of the emergency room, every day 1 ampule of adrenaline will be diluted and kept, and it will be in a loaded syringe with there will be marking on that when it is loaded and how long we can use that drug. It will be marked on the syringe itself. So it is very, very important to save the life in a busy emergency room. We have to load adrenaline and keep. And any procedure when you are doing, whatever may be the procedure which can produce hypotension and bradycardia and shock, or any condition which produces severe pain and hypotension, they're all we have to keep adrenaline ready, because in an emergency it will be very difficult to load the adrenaline during that emergency time. So we have to keep the adrenaline ready in any emergency room, otherwise we will not be able to use this drug in time. So this is a very important drug. We should learn about this drug. Any emergency physician or any emergency practitioner, doctor, nurse, emergency technician, they all should read about this important drug. Thank you.